Sachdeva, one of the mentors of StudyMEDIC, and today we are going to discuss about how do you approach certain stations related to postoperative care, and particularly we'll be dealing with stations on injury. So the major stations which you get on injury are bladder injury, ureteric injury. Then there is another station which comes on bowel injury and uterine perforation. So these are the stations you have to approach in similar manner, and most of these come as structured discussion. So the aim of today's discussion is how would you approach each of these cases and what are the important points to remember in regard to this, and what are the important points for which you have to touch on discussion regarding how do you describe the case, what is S bar, then what is the immediate management, what is the what is after management, like once you have immediately stabilized the patient, how would you manage the patient further in case you have reoperated, then post-op management, clinical governance issues. So this discussion would be pertaining on how do you deal with these cases. So first case is about bladder injury following total abdominal hysterectomy. So I'll just read this case for you. So this is a scenario, this is the kind of scenario you might get, that you are ST5 registrar doing an elective total abdominal hysterectomy for a 45-year-old woman with heavy menstrual bleeding, and you're being assisted by ST1. So they're giving you the situation. So this, you have to note down that these are the important points in the situation. Then this patient has, what are the risk factors for this patient? She has high BMI of 35 and history of previous 2 lower segment cesarean section. And how are you approaching the case? You have opened the abdomen using the previous Panel steel incision. And what happens next during the procedure, because of the dense adhesions which are present between the anterior abdominal wall and bladder, and while attempting adhesiolysis, an inadvertent bladder injury occurs. Now, the examiner will ask you questions. So whenever there is this structured discussion scenario, always remember you first introduce yourself, that you can say that hello or good morning or good afternoon. I'm Garima, one of the exam candidates, and I've read the scenario and I'm ready for structured discussion. So that's a standard introduction which you do. Hello, whatever your name is, and you are one of the exam candidate, and you have to tell that you have read the scenario, you know what is the scenario, and you are ready for structured discussion. Then wait for the examiner to ask questions rather than directly jumping to the scenario and jumping to answering questions. So always, because you will be marked on what are the examiner's expectations of you answering the questions, what are meant to be answered. So here the 4 important questions which I mean this might appear on your instructions, candidate instructions, or it might be impromptu. Like it might happen that you just go to the examiner and the examiner shoots the questions on you, and the questions are not available to you prior. So you have to be prepared for either of this case. So here I've given all the questions. So please summarize the case. What are the immediate steps? Further steps? Further steps you have to know, it should be always in terms of clinical and clinical governance. So there might be question about clinical governance, or this might be the last question, like how would you further manage the patient. So before jumping to clinical governance, you ask, once you're finished with your clinical management, you confirm with the examiner any further question is there, or can I complete with my discussion. That's how you can go ahead with it. So now coming to how would you summarize the first question, how would you summarize the case? So as I've already told, you always start with an introduction. Once you come, you greet the examiner. Hello, I'm Garima, one of the exam candidates. I've read the scenario and I'm ready for structured discussion. So you can follow it for all your structured discussion, the similar introduction, so that you do not get confused, because you know the time is always limited. So now how would you summarize the case? So even if it's not in the question to summarize the case. For structured discussion, it is always a good approach that you start with summarizing the case. Why? Because it gives you, like, it opens your mind. You know what are the important points that you have to deal with. What is the situation? What is the background? What will be the further assessment by you, and what will be your recommendations? So in this case, this is a the situation is, you were doing TAH for a 45-year lady. And why were you doing it? Because her heavy menstrual bleeding was not managed medically, and you were being assisted by ST1, and there had been an inadvertent bladder injury. In the background, it is a high risk case, as there is a history of previous to cesarean section and high BMI of 35. So what will be your and what has already been done? Because I mean, it gives you this scenario. Once you are summarizing, it helps you score, because the patient is already intra-op. Sometimes there are marks for patient safety in terms of WHO safety checklist, antibiotics. So it is a good idea that you can also approach like that. As per the pre-op, what all you would have done, you can explain, possibly done, like as per the pre-op routine, WHO safety checklist was done and pre-op antibiotics were given. And after that, after all the important pre-op checklist, you have, and the patient is put to sleep, and you have opened the abdomen through the previous cesarean section scar. There were adhesions which were encountered between the anterior abdominal wall and the bladder, and in attempt of adhesiolysis in order to push the bladder down, there has been inadvertent bladder injury. So this is situation and background. What will be your assessment? So keep it as brief as possible, but try to cover most of the points and try to analyze what are the important points in terms of patient safety, which could be assessed in your exam. Because sometimes these are the WHO safety checklist and pre-op antibiotics. These are in the, after checking allergy, these are all in the examiner's instruction as patient safety points. Okay, so now you would further assess the patient. The patient is like, you are doing the surgery, so you would further assess for further injuries and call for help, and your further recommendations will be based on your further assessment and what your consultant says. So this is how you summarize the case. Then what will be the immediate action? So immediate action is, you would immediately stop the surgery, cover the rent, because it's an open surgery, so you'll cover the rent once with a wet saline mop. Then you have to call for help. Whom should you call for help? You have to first of all tell the scrub nurse, OT team, anesthetist, and you need the consultant. Why do you need the scrub nurse? Because they would need further more instruments. So they might need additional instruments to be added in the trolley or to change the trolley. Why do you need, what do you need to, why do you need to tell it to the anesthetist? Because the surgery time would be prolonged. So the patient might need another IV cannula and more bloods, because in case such injury occurs, sometimes there is blood loss. So if the bloods were not already sent, they have to be sent for blood for group and save, and about the hemoglobin and full blood count. And IV antibiotics, if the time has elapsed, like if the patient is obese, if you need another dose of antibiotics, or if it was not previously given, you, like in surgeries like laparoscopy, you usually do not give, but in major surgery you usually give. If the antibiotics were not given, you will ask the anesthetist to give the antibiotics, and then you would inform the ask the scrub nurse, or you will to or circulating nurse to call the OT manager, so that they can inform the consultant, and they can also keep the other patients informed that the cases might get delayed. And if there is a case which is postponed, like at late during the time, if you want to allow them fluids for a little longer time, you can do that. So these are the people you would need to inform. This will be your immediate action. What will be the further steps? So what the next question that can come up to you is, what are the further steps? So in this case, you would proceed with a further repair only in the presence of the consultant. So you will say that you'll wait for the consultant to come in, And if required, you would involve the urologist. If you feel that the injuries are involving trigon and ureteric orifices, they are meant to be repaired by the urologist. Otherwise, simple bladder injuries can be repaired by trained gynecologist or a urogynecologist. Then you would look for inspect with the consultant, look for what is the site, because you need to inform the urologist if they have to come, what is the site size of rent. I- if you want, you will keep cystoscopy and methylene blue ready, and you'll involve the urologist. You will inspect for other, if there is no active bleeding in there. If there is any, you will try to control, look for other visceral injuries which might have occurred, and in case they are there, you will involve respective surgeons for them. So first of all, we'll wait for the consultant. With the consultant, inspect, look for other injuries and bleeding. Try to control the bleeding, and involve the urologist surgeons as and when required. And then you will proceed with your case. That is the hysterectomy. So you'll complete the hysterectomy. Remember, always in such cases, we'll complete the hysterectomy and then go ahead with repair of the bladder. So you can briefly tell about the steps of how you would go ahead, because you just entered and there was bladder injury, how you would go ahead with doing hysterectomy. Clamp, cut, ligate round ligament, then open the leaves abroad ligament, identify the bladder plane. I mean, it would be difficult with a bladder injury, depends on the extent actually. If you always try to push the bladder down, and then clamp, cut, ligate the uterine artery, then the McEnroe's uterosacral ligament should be clamp, cut, and ligated, then the uterine specimen delivered, vault closed, and then comes the role of the repair of the bladder end. So mostly they can be repaired by the gynecologist, but if they are involving ureteric orifice or trigon, always involve urologist. So you all know it has to be repaired in one or two. It can be repaired in one or two layers using. You have to name the suture. You usually use vicryl or 2O or 3O absorbable suture, which is also called as polygalactin, and you use running non-locking sutures, which are placed 0.5 to 1 centimeter apart, and 0.5 to 1 centimeter lateral to the cystotomy angle. So wherever it is broken, like where the incision, you extend your sutures 0.5 to 1 centimeter lateral to that. Then a repair, you have to talk about other important points about the repair. It should aim at to avoid any kind of obstruction to the ureters or the urethra. Ideally, the bladder repairs should be watertight, and they should be free of any sort of leakage and tension free. So this you can test using methylene blue. The suture line integrity should be tested, for example, either with methylene blue or indigo garment. And then you also have to tell about, once you have repaired the bladder, you've completed your procedure, you'll close the abdomen. Then you also have to mention about the post-op management. So in these patients, the bladder has to be kept for 2 weeks, and these patients would require prolonged antibiotics. And if in case in most of these cases, because in order to check there is no further leakage, because you repair the bladder, if the dent is big, you generally leave a drain in situ, so that in case any urinary collection, there is no urosepsis which occurs later, and any urinary collection can be drained off. And after the procedure, you will close the abdomen while ensuring uh, you do the other steps like WHO sign out, ensure the hemostasis, mop instrument count, everything has been done, and then the patient has to be shifted to HTU. You'll document everything in the case notes. That's the routine thing that you do, that you have to mention. And then about the post-op management. So post-op management will also be in terms of clinical and clinical governance. So what will be the clinical management? These patients are usually high-risk cases, so they have to be shifted to HTU for observation, and you have to do news charting for them. It is not news for non-pregnant patients. We use news chart. You'll give them broad spectrum antibiotics after ruling out allergy, and if you want, you can involve the microbiology department for them. BTE risk assessment has to be done, and then you can briefly mention about implementing enhanced recovery. That's possible. So you'll allow for early ambulation, allow early feeding. In case drains are there, you'll try to remove. There is no further leakage, you can just remove them within 24 hours if everything is normal. You teach the patient about, because the catheter has to stay in 24 for 2 weeks. So you have to explain the patient about how they have to take care of the catheter. If you have to call them to the hospital, or you have to attach a district nurse to take care of the catheter, you will arrange for all that, and then you will send routine bloods for them. Then what are the this was the clinical management. Then you have to briefly mention about clinically how would you manage. You have discussed about intra-op and then post-op management. Now now there are certain clinical governance issues which have to be specifically addressed. One thing you've already mentioned, that you will document everything in the case notes. You'll perform your duty of candor, that is, you'll debrief the patient and the relatives about the complication that has occurred, and you will apologize that this complication has occurred and you've done whatever best could be done, and you would be open and honest about the complication. And you this is an indication where you have to raise an incident report. You have to tell the patient that you will honest you can explain about the incident report as it is an internal investigations, and once the results of internal investigation, that is the incident report, is available, you would be open and honest in discussing the results with the patient in detail. And if the patient wants to complain, you would help them connecting to PALS after telling them that you've already initiated the incident report. Then because this is not a routine complication that occurs, so you'll involve the risk management team, and root cause analysis on has to be done to analyze the complication and implement any suitable changes in the care. And because you were involved in the care of the patient, you will for your own betterment, you will reflect on it, you'll write it in your e-portfolio and discuss with your clinical supervisor. And in case this is happening repeatedly, then it requires to be audited. So these are the important points. Like for any sort of injury, you have to touch on these points. So I've summarized it all for you. I'll just repeat it. You will document, perform your duty, document and debrief the patient, perform duty of candor, be open and honest, tell them, raise an incident report, tell them that you will be raising an internal investigation, and whatever the results will be informed to the patient in an open and honest way. And still, if the patient is very adamant and wants to complain, you would connect them to PALS. You'll involve the risk management team so that root cause analysis can be done. And for your own betterment, you'll reflect on it, write in your e-portfolio, discuss with your clinical supervisor. And if this is happening multiple times, then it has to be audited. And then another important part of the clinical governance is discharge advice. So you'll document everything about it in the discharge. And usually the discharge copies, one of the copy remains with the patient, the other goes to the remains in the hospital notes, the other goes to the patient, and one with the GP. So you'll write the letter to the GP. You will tell about the complications and if what extra care the patient might require. And once you are discharging, whenever you are discharging, you have to mention about the red flag signs, so that if the patient has any abdominal discharge, excessive abdominal pain, abdominal distension, or feeling unwell, or there is any fever, they have to come back immediately and give them 24 hours contact number. And if everything goes fine, they'll be once you have taught them catheter care, if they are able to do it themselves, that's okay. Otherwise, connect to the district nurse and call them to you after 2 weeks, or to the urologist after 2 weeks. After 2 weeks, usually retrograde cystography is done before the catheter removal. If everything is fine, we'll remove the catheter. So this was about how you go ahead with management of bladder injury. On similar lines, you will go ahead, you will manage the ureteric injury. So I would not, I'll just discuss important points. The other things are the same as bladder injury. So ureteric injury, the case that I have put it is we all know only 1/3 the ureteric injuries are recognized intraoperative. Most of the 2/3 of the cases are usually missed and recognized in the post-operative period, and such cases are mostly, if they're recognized later on, like very late, 10 to 14 days, these are usually electrosurgery related injury. So I'll just briefly read about this case. So this case, it is again a structured discussion. So most of the injury cases, would be structured discussion. Will assess patient safety, communication with colleagues, applied clinical knowledge. So you are ST5 on duty, and your ST1 comes to you because they have received a call phone call from the out of hour surgery, and they have accepted to see this lady in the emergency. She had a laparoscopy done 3 days ago for a suspected endometriosis, and now there is right sided loin pain and mild fever. The GP thinks she's significantly tender in her right loin, and you have advised to bring her into rule out ureteric injury, and your ST1 wants to discuss. So, like in this scenario, you do not have questions. So, you are discussing this case with your ST1, and the ST1, who is your examiner, would be putting questions impromptu to you. So, you can get a scenario like this as well. Okay, so these are the questions which are given to the trainee to ask you. So if you have got the case, usually they will tell, and then you try to summarize the case as I've already discussed previously in the SPAR format. Now the first question they ask you, how would you confirm the diagnosis? So confirming the diagnosis, we all know, first of all, first of all, you have to do clinical and radiological confirmation. So clinical, what are the symptoms? So you should know that you have to tell to the training what the patient should be assessed. So the head to toe assessment has to be done. That has to be done for everything, and then you have to check for signs of any sort of ureteric or bladder injury. Bladder injury, usually it is 50% are presence intra-op and 50% there is delayed presentation. But in this case, the trainee would tell you that he or she is suspecting ureteric injury, and how would you manage it. So first of all, how would you diagnose that it is ureteric? Now the patient has come to you. First of all, you will how would you diagnose? You will try to assess the patient's head to toe assessment. What do you want to look for? Is there any flank pain or any tenderness? How was the post-op recovery? Any hematuria, oliguria, anuria, or any unhealthy vaginal loss? And then once these symptoms, and you will palpate the abdomen for any tenderness, look for any swelling, distension, and look for the temperature. New starting has to be done. So definitely this patient requires admission, and you have to tell that you have to admit this patient for further assessment and recommendation. Okay, then you have to order. Once you have assessed, you will also other things that you have to look on in the patient's notes, that what was the patient, why was the surgery, was there any intra-op complication, any intra-op difficulty, was any pre-op antibiotics given or not, uh, how long the surgery took, when like was there any complication which was reported, and when was the patient discharged. So once you have taken all the information, the other things, in order to diagnose, you need to do certain investigations. The investigations would be ultrasound, CT, or a CT intravenous urography, which is the best to diagnose. And what are you looking for? You're looking for any sort of hydronephrosis, uroperitoneum, or urinoma. This patient has presented within 3 days, but usually if there is late presentation, you also have to keep in mind about thermal injury which might have occurred. So you have to discuss about this patient in a similar manner. So once you have told, how would you diagnose? So once you have confirmed with your CT-IVU, that the next question would be, you have confirmed with CT-IVU that it is a ureteric injury. Now how would you go ahead? So since it has been recognized, so this patient requires return to theatre. So whenever a patient is requiring return to theatre, or there is any injury, the incident report has to be done. This you have to remember. So first of all, you will call for help, because you just testify. You will need the help of the consultant to confirm the diagnosis, and in the surgery, the consultant should also be there. So you'll have a discussion with the consultant once the reports are available, and then who all the other because you are assessed on communication with colleague as well. So who are the other people you want to inform? You have to first of all debrief the patient that this sort of, because they have to know that this complication has occurred. Take a consent from the patient, document everything in the notes, and then discuss with have a discussion with the consultant. You need to inform the theater team. You have to take consent from the patient and inform the theater team. Inform the you would need a urologist, so involve a urologist and uh, shift the patient to theater. Then how would you manage? So they will ask about how would you repair. So then repair would be based on the site of injury. We all know, if it is upper third, you do end-to-end ureterostomy. If it is middle third, you do ureterostomy or ureterostomy, and lower third, you do ureteroneocystotomy, Suasage or Buhari's flap. So we all know that. And sometimes they can tell you that what the site of injury, and you have to explain how would you go ahead with it. And if it is usually these kind of injuries will not present, like minor crush injury, needle injury, they may or may not present, like the patients are not usually symptomatic and you usually do not do anything about it. So usually this is not something which will present to you. These are the major injuries which present later on are transaction or electrosurgical related injury, or it could be obstruction if you have accidentally ligated the ureter. And then whenever you are doing ureter repair, you put a DJ stent, double J stent, and you again post-op would be catheter for 2 weeks, and before removing the catheter you do retrograde cystourethropy, and then if everything is okay, then only repair. And when you're doing a repair, again you have to mention about methylene blue and how do you check. It should be watertight, tension free, spatulated fish mouth, and you have to confirm using methylene blue and all that. So this is how this would be the intra-op. Then post-op management is same as bladder injury. You'll shift the patient to HTU, start antibiotics, VT, thromboprophylaxis, news charting, if possible, put a drain in situ if possible, perform whatever the steps of enhanced recovery possible. Teach the patient about a post-op post-op bladder care and the catheter care. And if required, attached to a district nurse, you can go to their home for catheter care. Then this will be the clinical management. Clinical governance would be, once you have done the surgery, you will debrief the patient and the relatives, document everything in the case notes, then do your duty of candor, apologize. Incident reporting has to be done for this case, and tell the patient that you will inform them about the internal investigation. Be honest and open to them, but even if they want to complain, connect them to PALS. And for your own betterment, do a reflection on it, do write it in your e-portfolio, discuss with your supervisor, if required, involve risk management team to do root cause analysis, and if repeatedly it is occurring, then audits. And then you have to talk about discharge, mentioning your GP red flag signs to the patients. In a similar way, as I've told, for the bladder injury, you complete the station. So this is how you manage bladder and the ureteric injury, and similar way the bowel injury as well. So there is not much difference. So I hope with this you would be able to attempt these kind of stations in a very nice way, and they're easy only if you know how to attempt it. So this was about management of ureteric injury. Then there is another important station which comes about manage if there is they can give you a scenario. This is a little different from gynae. This is an obstetric case, like if you are doing suction evacuation, there was a uterine perforation. How would you manage? So I'll just read the scenario for you. This is the third case. You are ST5 on call, and your ST1 colleague is performing a suction evacuation for a 34-year-old woman with retained products of conception following a missed miscarriage. So this is the injury which has occurred following suction evacuation, which you were doing for RPOC. And this time your junior is doing the case, and while inserting the suction cannula, she experienced certain loss of resistance and is now concerned that she may have perforated the uterus. The patient is currently stable with no active bleeding or any sort of hemodynamic compromise, and your junior calls you for the immediate guidance and support. So you have to manage. The questions are the same: summarizing, immediate management, further management, and what are the clinical governance points. So, summarizing again, always in S bar. I'll just read it for you. So, this is a 34-year woman undergoing suction evacuation for RPOC, and during the procedure, the junior doctor experienced sudden loss of resistance, indicating uterine perforation. This is the situation, and the patient is currently stable with no active bleeding and or hemodynamic compromise, and but there is a concern that there could be possible uterine this, because you cannot be 100% sure that it is only uterine injury. Sometimes there could be adjacent visceral injury like bowel or bladder injury as well, so you have to mention about that. So you will assess the patient in the theater and decide on further steps such as need for performing a diagnostic laparoscopy, and the management will be based on further assessment and intraoperative findings. So this is how you summarize in SPAR format. Situation here, if you are given with the background, if there was any high risk case, you can say what is the background of the patient, your assessment, and what are your recommendations and management. So immediate. So you have to remember you are doing this procedure for retained products of conception. So that means you cannot just stop the procedure. You have to complete the procedure, because if you leave these products, they can later on cause infection. So you definitely have to keep complete the procedure. Unlike if it was just the dilator which had done the injury when you were doing hysteroscopy or something, where you can just stop the procedure if the patient is hemodynamically stable and observe. In this case, that is not the option. You have to complete the procedure. This is an important point that you have to remember. So immediate action for this case would be you'll stop the procedure, disconnect the suction cannula, then you'll call for help. You'll inform your scrub nurse, your OT team, anesthetist, get the consultant and loop. Uh, in this patient, you would need to complete the suction evacuation under laparoscopy guidance. So you'll ask the scrub nurse to get the instruments ready for laparoscopy. You'll ask the anesthetist, inform the anesthetist that they might need to prolong the anesthesia because suction evacuation is a small procedure. Usually, it's done under short GA. They do not intubate. The patient might require intubation when you're doing laparoscopy. And large bore IV cannula and IV antibiotics. For suction evacuation, generally you do not give IV antibiotics, but if there is an injury, you will have to give IV antibiotics. And OT manager has to be informed so that they can call the consultant. And in case there is any other injury, you might have to keep surgeon in loop. Then further steps: wait for the consultant to come. If required, if you're suspecting bowel or bladder injury, you can call them as well. On entry, like you have to do it. As I told you, you have to complete the procedure under laparoscopy guidance. So if you will go proceed with the laparoscopy once the consultant has come, and once you have inserted the scope, you will inspect for the site. You'll inspect what about the perforation and about the other injuries. So you'll inspect for the site and the size of the perforation, inspect if there is any active bleeding, any other visceral injuries like bowel, bladder. In case that is the case, involve the respective surgeons if there is any injury. And if required, like mostly if there is no injury, you can just under vision complete suction evacuation, and if required, just repair the rent. And in case you need to involve the surgeon, and you might like if there is bladder or bowel injury, sometimes you might need to convert to laparotomy. That's why in the consent you always take the consent of when you're doing suction evacuation, injury to the womb, injury to bowel bladder, going ahead with laparoscopy or laparotomy. So this should be included in the consent. Then you will if once you've ruled out there is no other injury, you'll complete the procedure under laparoscopy guidance. In case the perforation is small and not bleeding, it can be left alone, and the patient can be shifted to the H2 or to be just observed, new starting to be done. If the perforation is large and actively bleeding, that is a case when you have to actually repair it. And after once you've completed the procedure, you will close the abdomen as usual, do the WHO sign out, ensure hemostasis is secured, swab instrument count, that's the routine thing, and then shift to the patient to the H2 for routine care. Again, common steps: VT, risk assessment, follow enhanced recovery, early ambulation, early feeding if bowel there is no bowel injury and everything else is okay. In case you put the drain, try to remove it early. And catheter, again here, if there is no bladder injury, you can once the patient mobilized, you can remove the catheter. Document, and again you have to do clinical and governance things. So document everything in the case notes, perform duty of candor, raise the incident report, be honest to the patient, involve the risk management team, if required, root cause analysis. Uh, for your own betterment, do reflection, write in a portfolio, discuss with the supervisor. Now, if there is a perforation which is large and you've taken stitches, it weakens the uterus. So you have to also give a contraception advice to this patient. That's important patient safety advice, and you have to document in the note that the patient might need the because it is like a hysterectomy. So the patient would need there is a risk of scar rupture. So the patient would need cesarean in the subsequent pregnancy. So you have to document everything in the notes. So, and again, about the discharge, you will write everything in the discharge summary, write a letter to the GP, give a proper contraception advice is very, very important for such cases. Tell about the red flag signs and arrange a follow-up for the patient. So this is how you manage the cases of injury. So this is again the same thing which I've discussed. Um, so I hope once I've explained this, you would be able to manage if you get a structured discussion for management of any kind of injury. How do you summarize? What is the immediate management? What is the subsequent management? What is the post-op care? And what are the important clinical governance points? So the flow you go, and most of the points are same, only the management points would differ, intra-op management points would differ based on what the scenario is. This is again a flow chart from one of the doc articles about management of there is an ureteric injury. So we were mentioning here about surgical termination of pregnancy or evacuation of retained products of team. How do you manage? Or if this is again same, if you're using a bigger scope, and if the injury was when you're using any sort of resectoscope or any sort of energy, you'll alert the team. Catheterize if the catheter is not there. Oh, I didn't mention about the catheter. That's again very, very important. Observation, antibiotic, senior help, involve other specialities if required, convert to laparoscopy. Small perforation not needed, you just need to observe for 24 hours. If it is large perforation, you repair and keep the patient admitted for at least 24 hours. And in case there are other organs which are visceral injury or vascular injury, you will need conversion to laparotomy. So all these things you have to mention. So this was all about management of injuries. I hope it is clear. Thank you so much for your participation and active listening. Thank you.